Hello, everyone. Good evening for all of you. Let's start our revision. Hello, everyone. Good evening for all of you. Today, we will continue our free revision with the third lecture, the third revision. Okay. As usual, I will make all of you mute. Then, if you have any question, please raise your hand and open the mic and ask. Okay. Today, we will discuss about 20 questions, many of them from the previous exams. So let us start. The first question today. The interaction between aripiprazole and diltiazem. How can we solve any question like this, even if we don't know the interaction? How can we expect the answer, even if we don't know the interaction? Here we have a substance that inhibits the cytochromes. It is an enzyme inhibitor. Okay, so directly we can expect that this substance will cause what to the level of the other drug? Inhibitor increase the level of other drug. Okay, so the answer here will be number B. Okay, even you don't know the interaction or you didn't hear about it previously, you can expect the right answer by this way. Okay, by knowing the inducers and inhibitors. But take care, some interactions does not follow the effect of the cytochrome. Okay, so we firstly should know the interaction between the cytochrome. Then, if we have another interaction, we can know it. Let us see the second one. In which scenario the atenolol commonly used? Atenolol, what is the mechanism of action of atenolol? It is selective
blocker, beta-1 blocker.
Beta-1 blocker, yes. Selective beta-1 blocker can be used in many indications, many therapeutic uses, including angina, including arrhythmia. Okay, so let us see the choices. In moderate case of heart failure, after the loading dose of digoxin, after achieving normal digoxin level monitoring daily, or after MI with hypertension. This is the best choice for this. This is the best choice for this. For MI, beta blocker is important. After starting the heparin and warfarin and other drugs that used in the first attempt of the MI, you should continue with the beta blocker in order to make a relaxation for the heart, decrease the effort done by the heart. Okay, the heart here needs less effort. Plus the patient having hypertension, so this atenolol will correct both. When counseling a patient about proton pump inhibitor, which of the following statements is correct? The PPI cause hypermagnesemia, which is wrong. It will cause a hypo, not hyper. Hypomagnesemia. PPI should be taken before trying histamine blocker, or PPI may cause hypomagnesemia. This is the counseling point related to the proton pump inhibitor. Which is not correct about vasopressin. Vasopressin doing what? Vasopressin is one of the hormones secreted by posterior pituitary. Okay. Deficiency cause diabetes insipidus? Yes, it is right. This is a right statement. Action enhanced by alcohol? This is a wrong statement. Constrict blood vessels? Yes. Increase water reabsorption? Also yes. So the wrong statement here is that action does not enhance it by alcohol. Alcohol inhibits the release of vasopressin from the posterior pituitary gland, leading to decrease the level of circulating vasopressin. And this reduction in the vasopressin level interferes with the body's ability to regulate the water balance and concentrate urine effectively. As a result, alcohol consumption can cause increase in urine production, leading to more frequent urination and a potential increase in fluid loss from the body. Okay. This effect often referred to as alcohol-induced diuresis. Let us see the next one. Which of the following medication is known to cause hypokalemia as a side effect? We have many drugs that leads to hypokalemia. Let us remind or memorize some of them. Diuretics, but not all diuretics. Mostly thiazide and loop. While potassium-sparing diuretics will not cause hypokalemia. Instead of that, it will cause hyperkalemia. What else? Corticosteroids will cause hypokalemia. What else? Beta-2 agonist will cause hypokalemia. What about insulin? Insulin does insulin cause hyper or hypokalemia?
Hypo.
Hypokalemia. The presence of insulin in the blood making potassium escape into the cells. So the first line in treatment of hyperkalemia is
Regular insulin.
insulin, yes, regular insulin infusion plus dextrose. The infusion in dextrose bottle or glucose bottle. Okay, because insulin making an escape of potassium into the cell, from the blood into the cell. Okay, so let us see the question. Which of the following medication is known to cause hypokalemia as a side effect? Acetaminophen or paracetamol, ibuprofen, hydrochlorothiazide. It is one of the diuretics that leads to hypokalemia.
Sir, ACE inhibitors also cause hypokalemia.
ACE inhibitors cause hyperkalemia. ACE inhibitors or ARBs, both causing hyperkalemia, not hypokalemia. Ciprofloxacin should not be given with which of the following drugs or substance? To know this question, we have one information important for ciprofloxacin, or two main informations. Two main information. First one, it is inhibitor to cytochrome. Okay, so it may interact with other drugs leading to increase their level. So if the other drug is a serious or important drug, we should take care. The second important thing for ciprofloxacin or generally for quinolones, the QT prolongation. Okay, so if we have another drug acting as an antiarrhythmic or leading to QT prolongation, we should take care. We should not give them together. So let us see the options or the choices. Yes. Another thing, the third thing, minerals or antacids containing calcium, magnesium, aluminium. What happened here? There is a chelation for the molecule, then prevent its absorption. Those are the main three important information that you should know about the quinolones, and therefore the interaction with other drugs, mostly through those three information. Here we have antacids containing aluminium or magnesium. This is the drug that should not be used with ciprofloxacin at the same time. What you will do, make a separation between doses. Take a ciprofloxacin in a time and the antacid in another time.
Sir, option also contains calcium supplements.
Calcium supplements, yes, but the most is the aluminium and magnesium antacids. The aluminium and magnesium for a complex with ciprofloxacin more than calcium. It's right option also, but if you have those options together, choose the antacids containing aluminium and magnesium. Not a symptom of hyperthyroidism. To know this question and the answer of this question, let us see the symptoms of hyperthyroidism. Hyperthyroidism equal breakdown of main materials in the body. Breakdown of proteins, fats, carbohydrates, so increasing the metabolism. Okay, increasing the activity of the body. This is the hyperthyroidism. Anything opposite to that, it will be hypothyroidism. So increasing the activity, including the heart rate, the breathing rate, and so on. Tremors, it is a symptom. Tachycardia, it is a symptom. Decrease in appetite, it is not a symptom. The patient here having a hyperthyroidism will eat more and more, and this food will be metabolized and digested very fastly. So he will eat and he will not get weight. So this is the answer.
So weight loss occurs in this case.
Weight loss happened. It is a symptom. But weight gain is not a symptom of hyperthyroidism. It is a symptom of hypo. Even appetite increase, but the patient here have no weight gain. Okay. Why? This happened due to the increase of the digestion and metabolism of the main substance, due to the hyperthyroidism or due to the thyroid hormones. Okay, is it clear?
Yes, sir.
The next question. Which of the following cytochrome enzyme action is correct? Let us compare between the substance and the effect on the cytochrome. Smoking is a cytochrome 1A2 inducer. Is it correct or wrong? Yes, it is correct.
Right.
Tamoxifen is a cytochrome 2D6 substrate. Yes, like codeine. Codeine also will be metabolized by the same cytochrome. Clopidogrel is a substrate 2 cytochrome 2C19, also correct. Sanger's wort, or the other name of it, which is Hyperthyroid, is a cytochrome 3A4 inducer. Also, it is a correct statement. Clarithromycin is a substrate of cytochrome 3A4. Clarithromycin, one of the macrolides.
It's an inhibitor of 3A4.
Yes, it is an inhibitor. It is an inhibitor of 3A4. 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 It is an inhibitor not an inducer. It is one of the macrolides, like erythromycin. Both are inhibitors to cytochrome 3 4, while azithromycin, the other macrolide, not affecting the cytochrome. So when we have an interaction and we need macrolides, you can choose azithromycin. Which of the following is reason why ticarcellin is preferred over carbapenem? Okay, let us see this question. Ticarcellin has broader antimicrobial coverage. It is correct. Ticarcellin has lower risk of allergic reaction. No. Ticarcellin has longer T-half in the body. Or ticarcellin has lower incidence of gastrointestinal side effects. The right answer here is A. Ticarcellin has broader antimicrobial coverage. Okay, ticarcellin is a penicillin antibiotic that exhibits a wider spectrum of activity compared to carbapenem. It is effective against both gram-positive and gram-negative bacteria, including Pseudomonas aeruginosa, while carbapenem, on the other hand, has a limited activity against gram-negative organisms and mainly used against certain gram-positive bacteria. Okay, while the allergic reaction can occur with any penicillin antibiotic, there is no evidence to suggest that ticarcellin has a lower risk of allergy compared to carbapenem. Okay. Also, the half-life and gastrointestinal side effects may vary from different individuals, but not specific differentiating factors between ticarcellin and carbapenem.
Excuse me, sir.
Yes, please.
Carbapenem is active on gram-positive or gram-negative?
Mostly in gram-positive.
Okay, thank you.
Calculation problem. Let us see this one. To prepare a solution, here we need to prepare a solution of 25 millimoles per liter of sodium chloride. How many grams? We need the weight by grams, not by milligrams, of sodium chloride should be used for 1 liter solution. How can we solve this one? To prepare a solution of 25, we need to know what is the weight of sodium chloride present in this concentration. 25 millimoles per liter. So the first step is applying the formula that's saying that millimoles equal the weight in milligram over the molecular weight. Okay, then we can get the weight needed by milligram. We'll just multiply them millimoles, 25 by 58.5. Okay, then we get the weight by milligrams. Convert it into grams because he needs the result by grams. Just in one step. Okay. A 3-year-old boy diagnosed having otitis media has been prescribed amoxicillin suspension at a dose of 90 milligram per kg. 90 milligram per kg. Okay. For 5 days. Each day, he will receive 90 milligram per kg. His weight is 36 pounds. If the product in the pharmacy is present in the bottle and the bottle concentration is 250 milligram per 5 milliliters, and the doctor instructed to give it in 3 divided doses. Okay, how many milliliters of the total volume required? how many milliliter of the total volume required. Here, the first and important thing is to know the daily dose. Is it 90 milligram per kg? This is the total daily dose, or this is the one dose? Therefore, when we mention 3 divided doses, so the patient here or the child here will take every 8 hours, right? Does he will receive, or does he receive 90 milligram per kg every 8 hours, or he will receive 30 milligram per kg every 8 hours? So that the
30.
total daily dose will be 90 milligram per kg per day. What do you think about that?
I
Should
think
be
it's
30
90
milligrams.
per day.
30 milligram per kg every 8 hours. So that the total dose, according to the statement of the question, the total daily dose is 90 milligram per kg. Okay? So here we have two things. Firstly, converting the weight of the child to be a kilogram, then calculate the total daily dose and multiply it by 5 to know the total milligrams that this child will receive, right? How can we convert the kilogram or pound? Pound, 36 pound over 2.2. This is the weight by kilogram. Multiplied by 90. This will be the daily dose, 90 milligram. Okay. Multiplied by 5 to know the total milligrams per 5 days. Okay, so the result will be milligrams. This is the total milligrams for 5 days. Okay, then compare between the total milligrams and the bottle. 250 milligram present in 5 ml. The total milligrams that we calculated it present in how many milliliters? You will get the answer by this way. Is it clear?
Yes.
The next one.
Yes, sir.
Okay. The next one. Griseofulvine 50 grams added to glycerin 20 milliliter to form a paste. The density of the glycerin is 1.25 gram per ml. The final concentration of griseofulvine paste is. How can we solve a question like this? Okay, here we add 50 grams of griseofulvine to 20 milliliter of the paste. The paste is semi-solid, right? Glycerin here is a liquid. So we need to know the corresponding grams of this volume. How can we know that? By the value of the density. The value of the density helping us to know that. The density is saying that every 1.25 grams of glycerin equal 1 milliliter. Right? We have 20 milliliter. So how many grams of glycerin is corresponding to 20 milliliter? Let us calculate it. 20 multiplied by 1.25 over 1 equal 25 grams. So this paste now containing 25 grams of glycerin plus 50 grams of griseofulvine. Right? What is the total weight of this paste now? It is 75 grams. This is the total weight of the paste, which contains griseofulvine plus glycerin. So what is the concentration of the griseofulvine in this paste? It is 50 grams of griseofulvine present in 75 grams of the total paste. Can we get the percentage? Now it is easy. Consider that the total weight is 100 grams. Okay. So how many grams of the griseofulvine present in this? Let's multiply 50 by 100 over 75 to get the answer, which is 66.7. Is it clear?
Yes,
No,
sir.
sir. Kindly please
Yes,
repeat.
sir.
Okay. Which point is not clear with you? Try to think together. Let us think together. Which point is not clear with you?
The second step, 25 grams of glycerol.
Okay. Here we have a paste. Okay. This paste formed of two components, griseofulvine and glycerin. Right? We calculated the weight of the glycerin because he gives us the weight of I'm sorry, the volume of glycerin, but glycerin here inside the paste. So we should know the corresponding weight of it. We calculated it to be 25 grams. While he mentioned that we have 50 grams of griseofulvine. Okay, so the mixture here now composed of 50 grams of griseofulvine mixed with 25 grams of glycerin. What is the total weight of this mixture? 75 grams, right? Now we have a paste formed of 50 grams of griseofulvine present in 75 grams of the mixture. Right? Till now, do you have any problem? What is the concentration in this case? 50 present in 75. In order to get the percentage, we should make it in relation to 100 grams, the percentage weight per weight. Okay, so make the 75 as a 100. Now, the 50 becomes what? Just crisscross. You will get the answer, which is 66.7%. Is it clear now, or still you have a confusion about it?
Yes, clear. Thank you.
Yes, clear. But if the total weight of the paste is mentioned, then we will divide the concentration of griseofulvine in that total weight into 100.
Here, the total weight is not mentioned. What about if the total weight is mentioned? Okay. If suppose that the question asking about the griseofulvine 50 grams present in a paste of 75 grams. The same steps. Okay. Here, he excluded the step of converting glycerin into grams. Right? So directly use the last step. What would be the loading dose of a drug if desired peak concentration? 20 microgram per milliliter. And apparent volume of distribution is 4.5 liters. Let us see what we have and what is the formula that we will use. Here, he needs loading dose. In which concentration? In milligrams. Okay. What do we have? We have the concentration or the steady state concentration, which is 20 microgram per ml. Take care about the units. And the volume of distribution is 4.5 liter. What is the formula that we use? The formula is saying that loading dose equal plasma concentration or CSS here because we need the loading dose multiplied by the VD. Can we multiply 20 by 4.5 directly? It will be
No, we should
Mhm.
convert micro.
Yes, we should convert this microgram into milligrams, okay? And we should convert this liter into milliliter. So the CSS in this case will be 20 microgram to milligrams. What will we do? We just divide by 1000. So or multiply by 10 to the power minus 3. So this 20 multiplied by 10 to the power minus 3. Then 4.5 liter should be multiplied by 1000 or 10 to the power 3. Now we can multiply. Okay. So finally it will be 20 multiplied by 4.5. Okay. The answer will be 90 milligrams. Till now, do you have any question about the calculation problems that we discussed? Okay, let us see some other questions. Here it is a tricky one. Filgrastim is used to, what is the therapeutic use regarding to those choices? Reduce the risk of urinary tract infection or reduce the risk of peripheral neuropathy or reduce the risk of cardiotoxicity or reduce the risk of hemorrhagic cystitis. Let us think about that. What is the filgrastim? It is colony stimulating factor that enhance the production or synthesis of leukocytes so that it will prevent and treat neutropenia that happened due to the chemotherapeutic agents or due to the bone marrow depression. Okay? If neutropenia present for any person, he will be subjected to any infection. His immunity will be low. So when you treat the neutropenia, you will protect the patient from any infection. Therefore, the right answer here is reduce the risk of urinary tract infection. Not only urinary tract infection, but generally, it will protect against any other infection. Is it clear?
Yes, sir.
Which of the following is not a correct match? Let us focus on this question. Hypoparathyroidism. Here we have a low level of parathyroid hormone. Will cause hypocalcemia. Okay.
Yes,
Is it
that's right.
correct? Yes, it is a correct statement. Hypoparathyroidism cause hyperphosphatemia. Is it correct? Also, it is
Yes.
correct because calcium is opposite to phosphate. If we have a hypocalcemia, directly you will have a hyperphosphatemia. Hyperparathyroidism, including the parathyroid hormone, cause hypercalcemia. Is it right or wrong? Of course it's right.
Correct.
It's correct. Let's see the last one, which is the choice here. Hyperparathyroidism cause deficiency of calcium, which is wrong statement. Okay, here the action of parathyroid hormone and vitamin D and the relation between them and the calcium. Parathyroid hormone, like vitamin D, both of them will increase calcium level in the blood through different mechanisms. Through the kidney by increasing the reabsorption of calcium from the GIT, by increasing the absorption of calcium from the GIT, from the bone by increasing the resorption of calcium from the bones. Which of the following all close contact should be treated? In which condition all close contact should be treated? In head lice or scabies, or head lice and scabies, or scabies and pinworm? The right answer here is scabies and pinworm. About head lice here, not all household contacts should be treated, but all of them should be examined. And the person who has the head lice should be treated. Okay? And also, if the person share the items with the infected one, should be treated. In this case, he should be treated. While in case of scabies and in case of pinworm, all household contacts should be treated.
Sir, if in the option pinworm is not present, then can we select answer C?
No,
Because
C,
all are
C is
examined and
not
treated.
C is not a right answer. Even pinworm is not present. Why? I mentioned that. Head lice is not a condition that make all household contacts should be treated. They should be
Okay.
examined only. But if any person is infected, he should be treated. If not, he should not be treated. But if the person share the items with the infected person, he should be treated in this case.
Right.
Okay. Arrange the higher elemental iron to lower elemental iron supplement. Regarding to the salts of the iron, ferrous fumarate, sulfate, dried sulfate, or gluconate. Okay. The right order here, or the right elemental iron higher in which salt? It is fumarate. Then the dried sulfate, then sulfate, and then gluconate. Let us see the percentage or the amount of each salt, amount of iron in each salt. In fumarate, you'll find that it is 108 milligrams present in 325 milligrams. This means that it is about 33%. In the sulfate, it is an average of 26%. While the gluconate, you'll find that it is from 11 to 12%. Yes, you should know the percentage. It's not a big deal or not a difficult one. We have three salts. Just knowing that the percentage here, 33%, 26%, 11 to 12%. Okay? Which of the following opioids is least likely to cause serotonin syndrome? We know that the interaction between opioids and serotonin, and selective serotonin reuptake inhibitors may lead to serotonin syndrome because they will increase serotonin level. Both of them increase serotonin level. But some of the opioids have a little effect on this. Regarding to the choices, morphine, tramadol, fentanyl, or methadone, which is the least one? You'll find that morphine is the least one in this case. Some opioids that can cause serotonin syndrome are those that have serotoninergic properties, such as inhibiting serotonin reuptake and increasing serotonin level or activating serotonin. Okay, includes tramadol, meperidine, methadone, dextromethorphan. Okay. Other opioids that can cause serotonin syndrome are those that interact with other serotonergic medication, such as antidepressants, migraine medicines. Okay, include fentanyl, oxycodone, hydromorphone, morphine, or hydrocodone. Okay, so in this case, morphine is the opioid that has least likely to cause serotonin syndrome among the options present. Let us see this one. Usually used as a diagnostic test in active TB. Take care about this word, active. Because you'll find that all of them are diagnostic tests for TB. But which of them is in the active TB? Tuberculin Mantox test, chest X-ray, nucleic acid amplification test, or TB skin test. Regarding to those choices, chest X-ray will give us an indication that the TB is active, while others give us an indication that the patient having the antigen of TB. Either it is active or latent, we will not know. Okay, so the answer here is chest X-ray. I think it is the last question today. Yes, after the numbering is wrong here. This is number 20. What is the first line therapy in Lyme disease? It is doxycycline. Doxycycline is considered as the first line treatment for most cases of Lyme disease, particularly when the infection is localized to the skin or early localized or erythema migraines stage, or has spread to the joint, nervous system, or heart. It is highly effective against bacteria that cause Lyme disease, which called Borrelia burgdorferi. Yes, some questions in previous exams asked about the
Doctor,
causative
can you
organs.
please come to the question number 3?
Question number 3. Let's go back to question number 3. Not this. Sorry, question number 3.
Yes, about proton pump inhibitor. I also have a
Yes.
confusion.
Yeah. Isn't it the fourth D option? Because answer C is not related to any sort of counseling to a patient.
Yes, sir. Because antacid they increase the pH, so the entire coating will be destroyed. I think so. D will be the right answer.
It should not be taken with antacid.
Because
Mhm.
hypomagnesemia isn't related to something counseling to the patient.
Mhm.
Why shouldn't we go for the PPI should not be taken with the antacids?
Yes, I think you are right in this choice. Let me revise this point especially. I know that the PPI should not be received with the antacid at the same time. Do you know why?
Yes, sir.
They increase the pH.
Most of PPIs affected by the HCl of the stone. So they are administered as an enteric coated or as a capsule.
If you are going to give antacids,
Yes.
then the PPI wouldn't work, because the mechanism of action of antacids and PPIs are entirely different.
Here, the reason.
PPIs are related to the
Mhm.
secretion of the proton pump, whereas antacids will make
Because enteric
inner
coating.
coating.
Yes. The reason here, because the PPI is affected by the HCl of the stomach. If the
Yes.
PPI is administered as a normal tablet, not coated, it will be destroyed by the HCl.
HCl of the stomach. Yes.
Okay. So when you give antacid at the same time, what will happen to the pH of the stomach? It will decrease the pH of the stomach. Okay. I'm
Yes.
sorry, increase
Yes.
it.
Increase
Increase it. not
more
decrease.
more alkaline.
Yes.
Mm.
So the enteric coated tablet of the PPI will be released
In small intestine.
in the stomach, in this case.
Yes.
So the PPI in this case will be just subjected to the HCl that present.
Effect will be lost.
And the effect of PPI will be lesser. Okay, so you should make a separation between doses. You should not give them together at the same time. And let the PPI passing the stomach, they're reaching the intestine, and then release the drug and start to do its effect. Yes, I think this is the best counseling part. But let me revise it again. Is it present in the AMH or the other sources in Australia or not? Okay, let me revise it and I will inform you about this option. Is it D or C?
Okay.
But sometimes I see PPI يعني dispensed with antacid. A lot of time I see it. يعني, as an
But the
antacid
meaning-
usually a syrup. And,
the meaning here is taking at the same time, or we should separate between time, just 1 hour between both, or taking this in one
It could
time
be.
and this in
But
another
because
time.
in PPI, because hypomagnesemia is a correct status, يعني it's
Yes, both
correct
are
one.
correct.
يعني.
Both are
Mm.
correct. We don't discuss which is correct and which is incorrect. But here we discuss which is a counseling
Yeah.
and which is not
It
a
is-
counseling. This is the difference
Doctor,
here.
It is more related to counseling, and when the counseling is there, then we should ask the patient not to take PPI and antacid together. It must be somehow a difference of time. But the hypomagnesemia and other kinds of thing is not related to a person who is going to counsel a patient.
Yes, I understand your concept. Yes. So here we are discussing the counseling. Is it counseling or not? This
Yes.
point can be mentioned to the patient in your pharmacy or not. This is the counseling. Okay. So let me revise it again and go back to you. Yes, please.
Yeah, thank you so much, Dr. Ahmed, for just giving us a overview that is few of the costs. I just have a question, just general question regarding the exam. I put it on the chat. If you can just look on the chat and answer that, because a lot of us, in my friends and everywhere, they have a bit of curiosity about how can we pass the exam. I hope this will be feasible for you.
How can we pass the exam? It's a general question, a big one, but let us.
No, I just drop a query in the chat. If you can just have a look over there. Yeah.
I'll go back to chat and see your question. Okay, I think this is your question. I want to ask simply query. Can you please elaborate that if someone gets 6 calculation questions in his paper 2, is it necessary to correct at least half of questions? Is this your question?
Yeah. Same.
Okay. Let me say something. My recommendation in your exam, try to solve any question that you have without calculating if it is related to calculation or related to therapeutics or related to pharmaceutics and so on. This will make you confused sometimes and will take some of your concentration in the exam. Just solve any question that you have and try to solve it in the right way. Okay?
All right. Thank
Then,
you.
if you have a time at the end, when you revise the response, you can calculate that. But when you are solving the questions, try to solve as much as you can. Okay, and don't think about, is it related to which part, and which part will be affected. Okay, this will take a part or a big part of your concentration in the exam.
All right. Sure. Thank you so much.
Yeah. Generally, for sure, calculation is a part of the therapeutics. So it is considered as the 70% of the paper 2. As you know, therapeutics considered as a 70% of paper 2. You should solve 35% of them in the right choices or in the right way. Okay?
All right.
So if the calculation is a part of this, we cannot know. Sometimes in some models, you will find 10 calculation problems. This is the average, from 10 to 20 regarding to the previous exams. Okay? But I saw some models from previous members of our colleagues that who's finished the exam in the last model, in the last July. There was no calculation problems, or they didn't remember that they faced a calculation problem. Okay, so some models you'll find a very low number of calculation problems, 1 or 2, and some models you will find a 20 calculation problem. Okay? At the end, this calculation problem is a part of the therapeutics, which considered as a 70% of the paper 2.
What about chemistry part?
Chemistry part in paper 1,
Yes.
also chemistry is
30%.
considered as a 30% of the paper 1. So it's approximately 30 questions. This is the average. Okay, they mentioned that in the APC, Australian Pharmacy Council website, the official website, that the chemistry is 30% of paper 1. But due to the randomization of questions in the exam, they put the questions as a pool, then randomize the questions and make several models. So you may find maybe more than 30% or less than 30% according to the model that you will have. But this is the average percentage. Whatever the percentage, you should solve the question that you will face. And do not calculate if it is related to chemistry, related to pharmacology, related to whatever. You should solve as much as you can the questions that you face by the right answer.
Hello, doctor. I also have a question.
Yes, please.
You told that in scabies and in pinworm infestations, they are all close contact should be treated.
Yes.
But I read in chapter number 20, CPR, exercise question number 4, that all of the following treatments for personal articles infested with head lice would be affected. Placing woolen hats in a plastic bag for 2 weeks, machine washing clothes in hot water and drying them using the hot settling on the dryer, dry clean wooden scarves, and soaking hairbrushes in the hot water for 15 minutes. So these are all for the head lice infestation treatment.
Yes.
So isn't it the close contact treatment required head lice also?
What do you mention? You mentioned the items, not the person himself. All items should be cleaned. All items should be either, if it is washable, you should wash them with a certain way. And the unwashable items should be stored for 10 to 14 days. But he didn't mention the persons or the household persons himself. If you read in this part more and more in the CPR, you'll find that all household contact should be examined, not treated. Okay, this is the
Isn't
difference.
it the washing and with hot water, the drying is not a treatment?
It's not a treatment for the person.
It's
Do you
for
treat
the
the person here? Do you treat the person or protect him from the presence of head lice in other items? So when we use these items again, we will not affect it. It's not a treatment. Treatment means pyrethrin 1% for the person who is infected. Okay? If you read more in this point in the CPR itself, you'll find that all household members should be examined, not treated. And who of them will be treated? The infested person. Okay? And also, not the infested person, but the person who sharing the items with the infested person. So if you are in the same house, but not sharing the items with the infested person, it's not important to be treated. This is the meaning. Okay, is it clear now?
Yes.
Hello. Hello.
Yes.
Where can you last free revision I missed? So where can I find the free revision?
The free revision, the previous free revision, either from the website, you can go to this link. Okay.
Okay.
Then open the curriculum.
Yep.
Okay. In the curriculum, you'll find 9 lectures. 5 of them will be free. You can open them and listen to the videos. And
Thank you.
4 included in the course. So if you
Thank
want
you.
to listen to them, you should buy the course or the revision. Okay. Also, from another source, you can follow the channel.
Yep.
Channel in the YouTube. I shared the link of the YouTube channel, so you can listen to all videos that present in this channel. All of them are present.
All right. Dr. Ahmed, one last question from my side.
Mm-hmm.
Can you just please confirm alderonate, which one is bisphosphonate? It is responsible for hypoglycemia or hyperglycemia?
Which one? The
alderonate.
Alendronate.
Yeah.
Alendronate will not cause hypoglycemia, but it is not a must to cause hyperglycemia. Okay, so when you see a statement saying that the drug will not cause hypoglycemia, it's not meaning that it will cause the opposite condition.
All right.
Okay.
Yeah.
And also, finally, we have no absolute effects. Some patient may be affected. Some patient may have an effect that is not common. Okay, so it is not absolute for all patients or 100% of the patient. You should put this point in your mind as a general for all drugs.
All right, thank you.
Excuse me, sir.
Yes, please.
Sir, can you please tell us just hemorrhage cystitis? Because I found on the recalls there is a treatment of hemorrhage cystitis is MESNA, but there is a not full form.
Mesna.
Yeah,
Mesna.
Mesna.
Yes, it's
So
called
can
Mesna.
you tell me the Mesna and hemorrhage cystitis?
Mm-hmm. Hemorrhagic cystitis, firstly, it is a condition happened in the urinary blood. Happened mostly due to the chemotherapeutic agent, which is ifosfamide or cyclophosphamide alkylating agents. Okay. What happened or why hemorrhagic cystitis happened here? Because of the metabolism of ifosfamide or cyclophosphamide giving or forming a substance called acrolein.
Acrolein, yeah.
Yes. This acrolein is the reason for the hemorrhagic cystitis. Okay. What is the role of Mesna in this case? Mesna is a prophylactic treatment to protect against the hemorrhagic cystitis from ifosfamide and cyclophosphamide. Mesna will neutralize
Acrolein.
acrolein. Yes. Neutralize it and decrease its effect that causing hemorrhagic cystitis. Okay, is it clear?
Yes, sir. Thank you.
Any other question?
No, in the end, I just want to thank you for, just running the free session for us. It's really helpful. And, a thanks for all of us.
Thank you so much for your attendance. It's my pleasure to see you in the free. Still, we have another 2 free sessions in the coming week and the week after, just before the exam. And for sure, in our groups, our general groups, you can ask and share any question that you need, and whenever possible, I answer them. Still, the question number 3, I will revise it and inform you about it. Okay?
Yep, thank you.
Thank you so much. Thank you
Excuse me,
for
sir.
all of you. Yes, please.
Sir, actually, I was having a bit of confusion in the zero-order kinetics and first-order kinetics.
Mhm.
The zero-order kinetics, the elimination half-life, the elimination rate is independent of the concentration,
Mhm.
right?
Okay.
And so there was a question that zero-order is dose-dependent or not.
Mhm.
I'm not getting the answer for that because what I have read is about the elimination and the half-life. So can you please explain zero-order kinetics?
Let us clarify this thing and differentiate between the zero order and first order and some other important points. Firstly, you should differentiate by what is the factor that we are talking about. Are we talking about the elimination rate or the other kinetic or pharmacokinetic parameters related to the drug? When we are talking about the elimination rate,
Okay.
elimination rate, okay?
Yes.
The concentration starting from a higher point, okay, after administration and absorption and the drug reaching the higher level of it in the blood, the elimination start to have the effect, right?
Right.
In zero order, the elimination rate is constant.
Okay.
Whatever the concentration. So what I'm talking about now, I'm talking about the relation between the rate of elimination and the concentration of the drug. Does it affected by the concentration or not? Okay, so here the rate of elimination does not affected by concentration. It is concentration independent. Whatever the concentration, is it high or low? Same rate. It's like a train going to its way, whatever the number of passengers in this train, 100, 1,000, it's one direction, one rate, whatever the concentration. Okay, this is the zero order. While in first order, what happened? When the rate is high, when the concentration is high, the rate is high. Then the concentration decreased, the rate will decrease. Then the concentration decreased, the rate will decrease. So it will be a curved line. It is concentration dependent. Okay, again, what I am talking about, it is the relation between elimination rate and the concentration of the drug.
Concentration.
Yes, does it affect or not? When we are talking about the first order kinetics or zero order kinetics, what is the difference here? Or we compare between what?
Okay.
In zero and in first order. We compare between the dose and the concentration of the drug. The dose and the concentration of the drug. Okay?
Okay.
In zero order, which called non-linear pharmacokinetics. Okay? The zero order called non-linear. Why non-linear? Let us see.
Elimination, it doesn't affect by concentration.
Here we don't compare between the elimination rate and concentration. We compare between the dose and the concentration. Now, what is the effect of the dose on the concentration? When you give a low dose, the concentration of the drug starts to increase, right? Then increase the dose, what will happen? Generally, the concentration should increase. Then increase the dose again. Sometimes you will find that the concentration will go up directly like this. And sometimes you will find the concentration will go down. What happened here? Here, there is a saturation of one of the pharmacokinetics parameters. Let us give an example. Suppose that the saturation happened in the absorption parameter. When you give a dose, the site of absorption starts to absorb the drug and transfer it into the blood, right? Then you increase the dose, the concentration in the blood will increase. Then increase the dose again. Here, the site of absorption will be saturated. So the absorption will increase or decrease? Decrease, right?
Decrease.
And this will affect the concentration of the blood, of the drug in the blood. Therefore, you'll find that when you increase the dose, the concentration in the blood will decrease like this.
Decrease.
Because there is no absorption. All absorption sites saturated. Okay?
Okay.
Let us see another example. In the distribution, the first factor affecting the distribution is the protein binding, right? So when you increase the dose, the drug will pass, then start to bind to the protein in the blood. And the free concentration also increased in a certain rate. Then, when the binding site is occupied, all binding sites are occupied, what will happen? What will happen to the free concentration? It will increase. So by increasing the dose, you will find a very fast increase in the rate or in the concentration. You'll find the curve will be like this. Okay? So when I ask a question, the concentration of the drug in non-linear pharmacokinetics, is it dose dependent or not dose dependent?
Dose dependent.
Yes, it is dose dependent. It depends on the dose. Okay?
Okay. Okay.
Let
Thank
us
you.
understand the first order kinetics. Here, there is no saturation. The concentration does not affected by the dose. As the dose increase, the concentration increase like this. It is a linear pharmacokinetics. Okay, so as you increase the dose,
Yes.
you'll find that the corresponding concentration will increase by a or a stable rate like this. So it is dose independent. Also the T-half. Okay, T-half in linear pharmacokinetics is dose dependent, dose independent, while in the zero kinetics it is dose dependent. Is it clear for all of you or having some confusion about that?
It is clear, sir.
Thank you.
Thank you so much.
Excuse me, sir.
Yes, please.
Can you please explain again the relation between the dose and the half-life
The dose and half-life.
in the linear and non?
Simply by a very easy way to remember. You need to remember in the exam here. It is a certain situation you should remember. So let us put it like the following. Most of the drugs having a stable or a constant T-half or not. Most of them having a constant T-half. Whatever the dose, the T-half is known. Like, for example, digoxin having 30 to 40 hours. Fluoxetine, it is 5 weeks, and so on. This means that the T-half here, or the drug, is first order kinetic or linear pharmacokinetic. Okay, and T-half is dose independent. So the first order kinetics or linear pharmacokinetics, the T-half is dose independent. While drugs like phenytoin, for example, or heparin, do you have a certain T-half of them or not? There is no specific T-half. This is why it is because that those drugs follow the zero order kinetics or non-linear kinetics. So in the zero order kinetics, T-half is dose dependent. Whatever the dose, the T-half will be affected. Is it clear now?
Yeah, for example, if we increase the dose, the half-life will be increased.
Either increased or decreased according to other factors. But it is affected.
Yeah. In the first order, it will not be affected.
It will not affect it at all. So we called it dose independent.
Thank you very much, sir.
Half-life, but also parameters also follow the same scheme.
Yes, the same thing for all other parameters. The volume of distribution, the absorption, and metabolism, all of them having the same things.
Excuse me, sir.
Yes, please.
Sir, I have sent you a message in this chat. Can you see this about zero order? Is that correct?
Which
the chat?
The chat, yes. I'm now seeing the chat. Yes. Thank you for all informative lecture. Yes, this is this you mean? Yes.
This is a mnemonic from Dr. Gobind Rai Garg about zero order. I have sent you 0 watt power. Is that correct?
No, I'm not seeing it now. I try to find it, but I am not finding it.
It's from the YMS, sir. I have sent you in your personal chat, I guess.
Okay, send it again in my WhatsApp number or in the personal chat to answer. Okay.
Okay, sir. I'll send you.
Okay.
Thank you, sir. Allah Hafiz.
Thank you for all of you.
Thank you, sir.
Let me finish this session. Still, you have the opportunity to join the full revision. Still, it is present, so you can join at any time you want. You'll find all videos related to the full revision with more and more questions, more and more explanations, and the mock test also present in this full revision. Thank you so much, and see you in the coming week. Goodbye.
Thank you, sir.
Thank you, sir.
Yes, thank you.